Today, we are going to have very important diseases in sexually transmitted infection group. And as far as the practicing dermatologists of today, these two infections are not very commonly seen. But however, as postgraduate students, they may have some questions on this. And it is also mentioned that there is an increase in the incidence of chancroid in various parts of the world, especially in UK and US. So it is important to study these two diseases, chancroid and lymphogranuloma venereum. Lymphogranuloma venereum is not very common abroad. It is mainly seen in subcontinent of India. You might have heard about the classic monogram of lymphogranuloma venereum published by Dr. Raju and Rangaya. Anyway, we will go to the first speaker. The first speaker is Dr. a very good teacher, and she has active interest in sexually transmitted infections, and she is presently working as professor of dermatology in Government Medical College, Thrissur. Over to Priya.
A very good morning to all. Thank you, sir, for that kind introduction. At the outset, I would like to thank Crichton sir, who is my teacher, for the opportunity given to me. So the topic given to me is chancroid. As sir said, earlier in about 90s, the prevalence of chancroid was about 7 million, like that, globally. But after that, after the introduction of syndromic management, that is after 2000, the prevalence has decreased. That was in general with all bacterial STDs compared to viral STDs like herpes, condyloma, and etc. But again, now there is an increase in trend among the bacterial STDs, especially syphilis, gonococcal infection, and chancroid also, even though in our part of the country we are not seeing cases. Maybe we are missing some cases because the investigations of chancroid, it is difficult to confirm the diagnosis unless we do it in a very proper technique. And the higher end investigations like PCR and antigen detection, like etc., are not available to all of us, and they are very costly also. So we may not be able to do. So we may be missing some cases. So that is the importance of the topic today. So I'd like to discuss the topic under the following headings. So chancroid was a rare sexually transmitted infection until recent past, but now it is, as I said, it is increasing in UK. And knowledge regarding it, the true prevalence of chancroid is lacking because of its similar clinical presentation to other genital ulcer diseases and lack of a readily available diagnostic test. So we may be missing some cases of chancroid. And in the earlier days, it has contributed significantly to the HIV pandemic, especially in the sub-Saharan Africa and Asian countries. Few points regarding the history. It was Augusto Ducre in 1889 who has described the identified Haemophilus ducreyi as a causative agent. And Unna has described the gram-negative bacilli arrangement in chains. Ito and Reinsterna has carried out the intradermal test, which was being done earlier, but now it is not done because of non-availability of the antigen. Gonzalez Berries et al. Has conducted a systematic review in 2016 and they have published. And they have tried to identify the proportion of genital ulcer disease caused by H. ducreyi. And they have given a cutoff of 2000, year 2000, because it was in the year 2000 syndromic approach was introduced. So before 2000, the published data has shown that the prevalence of chancroid varied between 0 to 69%. And after 2000, the prevalence came down to 15%. So this decrease in the prevalence of chancroid was attributed to the widespread use of antibiotics following the syndromic management of the disease. The common age group affected is 20 to 40 years, and the disease is found to be more prevalent in the lower socioeconomic group. Infection, it will not confer immunity, and reinfection is possible. The male to female ratio is 1.6:1. So the factor one mentioned is the environment more common in males because of the environment provided by foreskin, which is favorable for the growth of H. ducreyi. And in females, the ulcers can occur in the hidden sites like in faucet and labia minora, where the ulcers can go unnoticed. And asymptomatic carrier state is also mentioned in females. So because of these reasons, the males are more commonly affected than females. The etiological agent is Haemophilus ducreyi. It is a pleomorphic, gram-negative, facultative, anaerobic bacillus. And they are non-motile, non-spore-forming rod with rounded ends. Antibiotic resistance is demonstrated with H. ducreyi and which is identified to be plasmid mediated. So the various antibiotics which we were using earlier are now found to be obsolete. The clinical features: incubation period. Chancroid is one among the STDs with a very short incubation period of about 1 to 5 days, may extend up to 7 days. And lesion starts as a soft, tender papule with an erythematous halo. And initially it can be a pustule and rupture to form an erosion and an ulcer in 24 to 48 hours. In males, the lesions will be painful genital ulcers, and inguinal tenderness can be present at the site of the lymphadenopathy. In females, the symptoms are less obvious. It can be asymptomatic, and patient can present with dyspareunia, pain on voiding or defecation. In chancroid, the ulcers are shallow, single, often multiple ulcers. As you can see in the picture, multiple ulcers which are tender and they can bleed readily on manipulation. And the edges you can see here, they are undermined and very sharp. The base will be non-indurated and the floor will be covered with a friable yellowish necrotic exudate. So the primary ulcer in chancroid is known as the soft chancre, in contrast to the hard chancre in syphilis, where the base will be indurated. The lesions, there can be lesions on the prepuce, which can manifest with, when the patients can manifest with paraphimosis or phimosis. And subpreputial discharge can be a presenting manifestation when the lesions are there on the prepuce. In males, the common sites are prepuce, frenulum, and coronal sulcus. The less frequent sites include glans meatus and shaft to penis. Rarely, the lesion can be in the urethra when the patient will present with purulent urethritis. In females, the common sites are faucet, labia minora, vestibule, and clitoris. And rare sites include the vagina, cervix, and perianal region. Extragenital lesions are also common due to autoinoculation of the bacteria. And the sites usually seen are tongue, fingers, lip, breast, oral mucosa, and thighs. Inguinal bubo, that is a lymphadenopathy, is known as inflammatory lymphadenopathy, is known as bubo. That usually starts here. You can see in the picture the inflamed, swelled up lymph nodes. So these bubo will start usually 3 days to 2 weeks following the primary lesion, and usually unilateral, and it will be tender inguinal adenitis. It will be a unilocular abscess with overlying erythematous skin. And the bubo can rupture to form an ulcer with thick, creamy discharge. The differential diagnosis is the bubo in LGV, which will be multilocular. There are certain clinical variants of chancroid. So one is the giant chancroid, where the ulcer is more than 2 centimeters in diameter. The ulcer can spread to suprapubic region or thigh associated with a ruptured suppurative inguinal bubo. So here you can see the ruptured bubo. Second is phagedenic chancroid or ulcus mole gangrenosum. The word meaning of ulcus is ulcer, mole means soft. So I told you the ulcer in chancroid is soft chancre. So ulcus mole gangrenosum, which will be a destructive ulcer with widespread necrosis of tissues. And this occurs due to superimposed infection with Vincent's fusus spirochetes. So here in the picture, you can see the external genitalia is almost destroyed due to the phagedenic chancroid. Third type is papillary chancroid, that is ulcus mole elevatum. It starts as an ulcer but later become raised, particularly at its edges. And the differential diagnosis for this can be condyloma lateral lesion of secondary syphilis. Transient chancroid, otherwise known as chancre malevolent, it's present as a small ulcer that heals in few days. And regional lymphadenitis can start in 2 to 3 weeks. And since it is a very small ulcer, it can go unnoticed, and it mimic the ulcer of transient chancroid can mimic like that of LGV, where also you get a transient ulcer. So this transient chancroid, the differential diagnosis mentioned is similar to inguinal syndrome of LGV, where the patient will be presenting with the regional lymphadenitis. Next is dwarf chancroid or ulcus mole, which resembles erosions of herpes genitalis, but the lesion has irregular floor and sharply cut hemorrhagic edges. Follicular chancroid is another variant. It simulates the pyogenic folliculitis. So it's a very superficial, and the pustule can soon ulcerate. The next type is serpiginous chancroid or ulcus mole serpiginosum. You can see here a long ulcer. So this long and narrow ulcer has formed by confluence and auto-inoculation of multiple ulcers. The other variant is granulomatous chancroid, where the ulcer can resemble that of donovanosis or granuloma inguinale. So all these clinical types are mentioned here. It can mimic various types of STDs. And in some cases, non-STI infections also can present with genital ulcer diseases. So that is a difficulty in making a diagnosis of chancroid with such varied clinical presentation, mimicking even a normal pyoderma. These are two terms associated with chancroid. That is, one is mixed chancroid, which is where there is a combination of chancroid and syphilis. So the patient will be having tender, non-indurated ulcer suggestive of chancroid, along with the syphilitic, non-tender and indurated ulcers. So the two can coexist. So this also you should not miss. The another term is chancroidal ulcer, where the genital ulcers that are clinically akin to chancroid, but H. ducreyi cannot be demonstrated. For example, you can get patients with herpes simplex, where there can be a secondary infection with pyogenic bacteria, and that is an example for chancroidal ulcer. Now, what happens when chancroid and HIV coexist? So, In case of chancroid, when there is an HIV infection in a patient with HIV infection, the clinical presentation can be altered. It can present with extensive necrotizing lesions, multiple or multilocular bubos, and massive bleeding can be there from the ulcer. Here you can see the perianal lesion, which is an atypical site with multiple lesions. And in the presence of chancroid, the risk of HIV transmission is increased by 4 to 10 times as it is an ulcerative STD. Now, what are the complications? The complications are that can rupture of the inguinal bubo can occur, where the patient can present with sinus or ulcer, balanitis and belnoposthitis when there are lesions on the glands. If the lesions are there on the prepuce, patient can have phimosis or paraphimosis, which may need surgical intervention sometimes. Secondary infection with anaerobes can lead on to gangrenous phagedenic ulcer. And in case of phagedenic chancroid, urethral and rectovaginal fistula also can occur. So if you're not diagnosing the case properly at the right time and managing the infection, all these complications are likely. Now, the differential diagnosis for the ulcer of chancroid, I told you most of the ulcerative STIs and non-STI diseases can also mimic chancroid. Examples are syphilis, where the ulcer will be a hard chancre, mixed chancre, which I told you earlier, combination of chancroid and syphilis. In LGV, the ulcer can be transient with inguinal lymphadenitis. Donovanosis, the ulcer will be how to differentiate donovanosis. Ulcerating granulomatous masses which bleed easily with beefy red granulation tissue. In herpes genitalis, the primary lesions will be vesicles which rupture to form erosions with polycyclic borders. And non-STA conditions like Behçet's disease and extracutaneous Crohn's disease, all these can present with genital ulcers. So there are a lot of differential diagnoses. And the inguinal swelling in chancroid can mimic the LGV bubo, where it will be multilocular. And donovanosis, it is pseudo bubo, which is a misnomer. They are actually not inguinal nodes. They are the subcutaneous granulomata of the disease per se in the inguinal region. So these are the differential diagnosis for the ulcer and the inguinal bubo. Now coming to the investigations, these are the array of investigations available, that is smear, culture, non-culture techniques, serology, mass spectrometry, and histopathology. Now the smear, it has to be taken from the base of the ulcer or from the pus aspirated from bubo. And in order for taking the smear, a cotton or calcium alginate swab can be used. And to maintain the morphology of bacteria, a rolled smear is recommended. So what is a roll smear? You roll a sterile swab in one direction beneath the undermined edge of the ulcer and re-roll the swab in the reverse direction at 180 degree on a clean glass slide. So unless you are taking in this right way, you need not get the classical arrangement of the bacilli. And the smear can be stained with grams or GMs stain. So I will show you a demonstration of how to take a roll smear. So this is a patient with multiple genital ulcers. The smear should be taken with a cotton swab, should be rolled on the undermined edge in one direction. And then it has to be smeared, re-rolled in a reverse direction on the glass slide. And such a smear to be made. So that is what is known as a roll smear. Only then you will get the classical arrangement, that is a gram negative cocoa bacilli in end-to-end chains, as here. Slideshow. 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 So the smear and end-to-end chains, the arrangement of school of fish or railroad track of fingerprint appearance. And the microscopy is only 50% sensitive. So if you're not taking a proper roll smear, it is difficult to see the arrangement and you can miss the diagnosis. Culture, since the organism is a fastidious organism, it is difficult to grow in culture, and isolation rate in culture is only 50 to 80%. And specialized media are needed for culture, and the culture media are gonococcal agar with 2% bovine hemoglobin and 5% fetal calf serum, or Muller Hinton agar with 5% chocolate host blood, because hemin is required for the growth of the organism. And the culture chance is only 50 to 80%, so this also cannot be always diagnostic. So the colonies, you can see here, they are small, non-mucoid, yellow-gray, semi-opaque or translucent colonies, which appear in 2 to 7 days, shown in this picture. And the colonies are identified by a combination of biochemical tests, that is oxidase test, nitrate reduction, porphyrin test, and for hemin requirement. So these biochemical tests are to be done. The non-culture diagnostic tests available are DNA amplification technique and antigen detection. So PCR is one method which is very sensitive, and now multiplex PCR is also available, which can diagnose chancroid, syphilis, and herpes simplex infection simultaneously. So this is a very sensitive technique, but it is costly and is available only in few centers. Antigen detection is also possible with monoclonal antibodies directed against the membrane proteins of H. Ducrey. Various serological tests are available, which are enzyme immunoassays, dot immunobinding, agglutination, complement fixation, and precipitation techniques. But the pitfalls of serological tests are due to the presence of cross-reacting antibodies to other Haemophilus species, and they cannot distinguish between remote and recent infection. But the serological tests are a useful tool for large-scale epidemiological studies at the community level. Mass spectrometric method, that is a Malditov assay, that is also a very sensitive technique. The advantages are they can rapidly identify Haemophilus bacteria, can determine the strain differences between different H. Ducrey isolate. Antibiotic susceptibility testing is also possible, but this also is costly and available only in few centers, so we may not be able to do this. Histopathology of chancroid is very suggestive. The characteristic 3 vertical zones with the vascular changes. The surface zone of the ulcer is rather narrow and consists of neutrophils, fibrin, erythrocytes, and necrotic tissue. The middle zone is fairly wide and contains mainly newly formed blood vessels. The deep zone is composed of a dense infiltrative plasma cells and lymphoid cells. But usually we don't go for biopsy unless we suspect malignancy in case of a genital ulcer. So in order to confirm the diagnosis of chancroid, that is mainly based on the characteristic clinical presentation of chancroid, that is a soft sore, tender with non-indurated base which bleeds on touch, multiple ulcers, and you have to rule out the presence of other ulcerative diseases like syphilis and herpes simplex. Syphilis, in order to ruling out syphilis, you have to do a dark ground illumination from the ulcer exudate, or a serological test for syphilis, which should be performed at least 7 days after the onset of ulcers, since VDRL may become positive only after 7 to 14 days of the ulcer. And for HSV, the PCR, herpes simplex virus, PCR or HSV culture should be negative. In addition to this, HIV test for HIV infection should be done, And if it is negative at the first time, the test for HIV as well as the serology for syphilis should be repeated after 3 months. So that is how we make to confirm the diagnosis of chancroid. So the treatment options, the local treatment is important. Cleansing is very important. Subpreputial irrigation with normal saline is essential because lesions can be there at that site. For treatment of bubo, aspiration with a wide bore needle through a non-dependent normal skin. That is done through a non-dependent normal skin in order to prevent sinus formation. Incision and drainage is contraindicated in this case because that can lead on to a non-healing ulcer and a persistent granulomatous tissue formation in that area. Various systemic treatment options are mentioned available for chancroid according to WHO, CDC, and NACO. But what is preferred is the single dose regimens, that is azithromycin 1 gram orally single dose, or ceftriaxone, injection ceftriaxone 250 milligram IM in a single dose because of the convenience. The antibiotic susceptibility pattern of H. ducrei has changed over time. I told you the plasmid mediated resistance is demonstrated for antibiotics like penicillin, sulfonamides, chloramphenicol, tetracyclines, and kanamycin, which we were using earlier, but now not. In phagedenic chancroid, the treatment option is benzyl penicillin 1 million units 8 hourly, along with oral metronidazole 200 milligram TID for 7 to 10 days, and it should be given in addition to the standard treatment for chancroid. The syndromic management for genital ulcer disease, non-herpetic bits and chancroid comes under this. So that is a white kit where the treatment for chancroid, the drug is tab azithromycin 1 gram single dose and injection benzathine penicillin to target syphilis. How to follow up the patient? The patient to be followed up 3 to 7 days after initiation of therapy. And if there is no clinical improvement, you have to suspect the following factors. That is, the diagnosis may be incorrect. It could be some other cause. Co-infection with another STI agent. The patient can be HIV infected. Treatment might not have taken as instructed. And the H. ducrei strain causing infection is resistant to the prescribed antimicrobial. So you have to think of all these reasons and act accordingly. Now, how to manage the sexual partners? Partners of patients who have chancroid should be examined and treated regardless of whether the symptoms of the disease are present. If they had a sexual contact with a patient during the 10 days preceding the onset of symptoms in the patient. So this you have to keep in mind and examine the sexual partner if the contact has occurred within 10 days, irrespective of whether they have the symptoms or not. The prevention and control to some extent is possible in case of chancroid by washing the genitalia within a few hours of sexual exposure and emphasize on condom usage, registration, regular examination, and prompt treatment of sex workers by the syndromic approach. To conclude, chancroid, it is characterized by a soft sore, non-indurated base, multiple ulcers usually, and tender ulcers which can bleed easily on touch. And regional lymphadenopathy develop in approximately 50% of cases, and the inguinal bubo can follow about 2 to 3 weeks after the soft chancre. To confirm the diagnosis, it is difficult. I told you it is mainly a clinical diagnosis by ruling out all the other causes for the genital ulcer. And unless you take a proper roll smear, you may not get the school of fish appearance, which is characteristic of chancroid. So try to take the smear in that correct method. And single antibiotic treatment preferred with tab azithromycin 1 gram or injection ceftriaxone 250 milligram IM stat. And since chancroid is a significant cofactor in the transmission of HIV disease, all of us has to keep an open mind for the diagnosis of chancroid. So these are my references. Thank you for the patient listening.
Thank you, Dr. Priya. It's a very clear and lucid, simple talk. Everybody could understand all what you have told during the talk. And it is very easy for the postgraduates to understand the intricacies of various other sexually transmitted infections. So congratulations.
Thank
And
you, sir. Thank
keep
you.
coming once again.
You straighten, sir.
Thank you.
Thank you, sir. Thank you.
I think we will be a very enthusiastic, energetic dermatologist of Kerala. She is presently working in Thrissur Medical College, and the place where Dr. Priya is also working. And she had a training in leprosy recently in China. And today she is talking about not leprosy, but sexually transmitted infections, and that too lymphogranuloma venereum. Lymphogranuloma venereum is not a very common disease as far as the practicing dermatologists, but we have to understand the various manifestations of lymphogranuloma venereum. And it is, of course, the sequelae of lymphogranuloma venereum is very frustrating. So initial recognition and proper treatment is most important to avoid such complications. Over to Dr. Betsy.
At the very outset, I thank my own Crichton sir, who was my mentor and my teacher, for giving me an opportunity to talk on lymphogranuloma venereum in this platform. I also thank East West Pharma for giving this opportunity. So without much ado, we'll go into the topic. Many of the things have already been discussed by my previous speaker, so it is quite easy for me to go to the same, which is a close differential diagnosis of chancroid. LGV, first the historical aspects and epidemiology, then the clinical presentation and complications, differential diagnosis, investigations, and treatment. So under these headings, we can discuss LGV. There are a lot of synonyms for lymphogranuloma venereum. If you remove the first word, the lympho, then it is the same term used. Granuloma venereum has been used for dona venosus also. So for postgraduates, you should not get confused when they ask these terms in exams. The other synonyms which have been used are lymphopathia venerea, because it is a venereal disease which has a predilection for the lymphatics. And that's why it's also called as lymphopathia venerea. And it has been described in tropical countries and hence also called as the tropical bubo or the climatic bubo or stromas bubo. And because of the inflammatory nature and matting of lymph nodes, it's also called as sporadenitis inguinales or lymphogranuloma inguinale. And the first clinicopathological description was by Nicolas and Favre disease. The V that is pronounced later in French, and so it's called as Durand, Nicolas, and Favre disease. So coming to the historical aspects, the first description of LGV was by Wallace in the year 1833. And it was Caddy in the year 1902 who first recorded the cases in India under the title climatic bubo. Now, as I said earlier, the first clinical and histopathological entity of LGV was described by Durand, Nicolas, and Favre in the year 1913 and differentiated it from other conditions like syphilis and tuberculosis and gave the name lymphogranuloma inguinale. Now, the first to describe or to isolate the causative organism were Hellestrom and Wasson in the year 1930. And it was thought to be a virus. It had properties of both virus and bacteria. And Freis in the year 1925 introduced the first intracutaneous test, which is no longer used nowadays. It's mainly of a historic interest. And the first person to grow the organism in chick embryo was Miyazawa, and it's sometimes described as Miyazawa inclusion bodies. It grew the organism in chick embryo in the year 1935. Now, the first monogram, as already Crichton sir has mentioned, the first Indians who described a detailed monogram on LGV were Rajam and Rengayya in the year 1955. Initially, LGV was described in heterosexuals in tropical countries like Africa, India, and also in parts of Southeast Asia, South America, and Caribbean, where the main manifestation were in the form of genital ulcers and lymphadenopathy. But nowadays, the epidemic has been changed more into the MSM population. And so the manifestations have also shifted from genital ulcers to more of proctitis. So one of the common common manifestation of LGV is now proctitis. And the first case of proctitis reported from India in a bisexual person was in the year 2017. So we expect more and more cases to occur in future because of the MSM population is also increasing in our country. And the changing sexual practices like receptive anal sex and oral sex, and also women indulging in receptive anal sex all contribute to the increase in number of cases of LGV all over the world. In India, cases reported from India very few probably because of the lack of availability of this PCR, multiplex PCR, which is needed to differentiate chlamydia from the other LGV chlamydia, which are L1, L2, L3, from other biovars of chlamydia, which cause non-gonococcal urethritis. So the recent outbreak which occurred in Europe, Spain, Portugal, Amsterdam, and Netherlands was by the strain LGV L2B, and it caused an outbreak in MSM population as proctitis. So the incubation period has some overlap with chancroid, but it is much longer than chancroid. So it can start from 5 to 21 days. So it's longer than chancroid. Chancroid and herpes have the shortest incubation period of about less than a week. But this incubation period can get prolonged. Maybe it can go up to 1 month. The usual initial manifestations are, like I said, in MSM population, they can present with discharge from the rectum, tenesmus, or rectal ulcers or perianal ulcers. It can also present as a genital ulcer depending on the site of inoculum. It can be a transient painless genital ulcer. They can also present with tender abscess over the penis, which are called as bubonules. And the bubo, as already mentioned in chancroid, is unilateral in 2/3 the cases and bilateral in about 1/3 the cases. So what are the 3 stages? LGV has early and late manifestations, and it has been described in 3 stages: primary, secondary, and tertiary stage. So the primary stage is based on the site of inoculum, where they can present with genital, anal, or oral ulcers based on the way in which they practice their sex. So it can present as a transient herpetiform ulcer which heals without a scar. The other presentations are proctitis, urethritis, which can mimic non-gonococcal urethritis, or balanitis or balanoposthitis, or even cervicitis in females, as it has a predilection for the columnar epithelium. So just like you get non-gonococcal urethritis and cervicitis, here also you can get cervicitis and its complications like endometritis, salpingitis, and infertility. So these are the primary manifestations, and that's called the primary stage of LGV. Then it can go on to the inguinal syndrome. That is called the secondary stage, and the late manifestations are described in the tertiary stage, which you called as the Genito-ano-rectal syndrome, or even the Urethro-ano-rectal syndrome. Now, the clinical features, apart from the urethritis or the proctitis or genital ulcer, as I mentioned, you can get bubonules, like the abscess that you get along the dorsum of penis, lymphangitis of penis, or you can get local edema over the penis in males or vulva in females. And sometimes it can even lead on to phimosis in males. If it has an inoculum in the cervix, it can lead on to cervicitis, which can later extend into the endometrium, causing endometritis, salpingitis, and even pelvic inflammatory disease. So we should know the lymph nodes. The primary LGV determines the lymphatic involvement. So only in sites like the anterior part of the urethra or the glans penis, vulva, and the anus, the lymphatics will drain into the inguinal nodes, and where you get an inguinal bubo. In all other situations, if the inoculum goes into the posterior urethra, into the vagina and cervix, upper part of the vagina and cervix, they drain into the deep iliac lymph nodes, and they go to the perirectal lymph nodes, the lumbosacral lymph nodes, and that will be responsible for the ano-rectal syndrome. So inoculum, where is the initial inoculum will determine the lymphatic spread. Even if the inoculum is in the rectum, again you get the late manifestations like the ano-rectal syndrome, which we come to it later. So the secondary stage is called as the inguinal bubo, which will appear about 2 to 6 weeks to up to 4 to 6 months after the onset of the primary stage. So there can be a delay up to 4 to 6 months for the development of bubo. Usually it appears within 2 weeks. And they present as a tender swelling. So if you compare it with chancroid, as already mentioned, here the bubo will be multilocular. That means you get multiple points of fluctuation. And unlike the chancroid, which breaks open to form a chancroidal ulcer, there is no ulceration, but instead you get multiple sinuses. The multiloculated bubo will break open to form multiple sinuses. And the overlying skin becomes adherent, and there can be change in color of the skin, in that it becomes violaceous, and that is an indication that it's going to rupture. So another sign which has been described in LGV is the groove sign of Greenblatt. There is in about 20% of the cases, the femoral lymph nodes are also affected, and they can be separated by the inguinal ligament. So the inguinal ligament separates it into lymph nodes above and below the inguinal ligament will be responsible for the sign of groove, which has been described by Greenblatt. And this sign is quite specific for LGV, but it has been described in conditions like lymphoma also. So if you, after treatment, because mostly it is an empirical treatment, and if it doesn't respond, you should go for a biopsy and think of other diagnoses like malignancy or lymphoma. Now, about 1/3 of the cases of inguinal bubos can become fluctuant and they rupture. And the blue color or the violaceous color, blue balls, it's called as blue balls that predict the rupture of the bubo. So that is an indication to aspirate the bubo. You may have to aspirate it multiple times to prevent it from rupturing. Rupturing can lead on to further scarring and fibrosis. So in order to prevent that, we can aspirate from a non-dependent portion. Now, these sinus tracts, they heal slowly, leaving contracted scars. And if the bubo is bilateral, the chance of developing late complications like elephantiasis is much more when compared to a unilateral bubo. A bubonic relapse can occur in about 20% of the untreated cases. And in females, as I said earlier, the deep iliac lymph nodes get involved in about 75% cases, and they can form a pelvic mass. And so a deep examination of the abdomen is very important. And sometimes even it can be mistaken for appendix mass. And by manual examination also is warranted in order to prevent missing these involvement of the deeper lymph nodes. So the secondary stage, the adenitis will separate, especially if it is inguinal. In about 60 to 70% of the cases, the adenitis, the inguinal bubo is going to separate and it may rupture. The spontaneous resolution is seen in about 25 to 30% cases. And luckily, the inguinal lymph nodes will not separate. And the sinuses can persist for months, and they can get secondarily infected and heal with scars. And in women as such, only 20 to 30% of the women will suffer from inguinal syndrome. And the pelvic mass, which I said earlier, can result in urinary retention and cystitis. Adhesions can occur with the surrounding pelvic organs, and that can result in frozen pelvis, which is described in the late manifestations of LGV. And during the secondary stage, you can get systemic spread of the organism. So apart from the lymphatics, you can get a blood spread, and they can have systemic symptoms like fever, arthritis, arthralgia, hepatitis, pneumonitis, meningoencephalitis, and endocarditis. So a thorough systemic examination has to be done in order to so that we don't miss any complications of LGV, which can occur rarely if not treated early. And the cutaneous manifestations can be in the form of a rash, which is described as the Song-Sola rash, a photosensitive type of rash, and non-specific manifestations like erythema nodosum, erythema multiforme, and id reaction are all described as non-specific cutaneous manifestations which occur as a result of systemic spread. And ocular symptoms as a part of direct by autoinoculation or by hypersensitivity phenomenon, it can cause conjunctivitis, episcleritis, or iritis. Now, going on to the tertiary stage of LGV, which is called as the Genito-ano-rectal syndrome, or if it is affecting the urethra, you can get Urethro-ano-rectal syndrome. It is not very common. It is seen in around 25% of the untreated cases. So as I mentioned, bilateral bubo can lead on to lymphatic obstruction, fibrosis, and genital elephantiasis, which is often described as osteomy. Penile and scrotal elephantiasis in males can lead on to ramrod or saxophone penis. Vascular compromise can lead on to ulceration of the genital skin. So in tertiary stage also, you get genital ulcers as a part of vascular compromise. You can get polypoid swelling due to obstruction in the form of lympharoids. And in females, the involvement of the deep pelvic nodes lead to elephantiasis of the vulva, clitoris, perianal region, and again, chronic genital ulcers. And it can cause perforating ulcers, and that can lead on to urethral and vaginal stenosis, strictures, and fistula due to perforating ulcers. So you can get rectovaginal, urethrovaginal, ano-rectal fistulas and strictures as a late complication of LGV. So the ano-rectal syndrome can be by direct inoculation, as in case of MSM having anal sex, or even in females who practice anal sex, or it can be a spread from the deeper lymphatics. So it can be a primary thing, or it can be due to a retrograde lymphatic spread. And it can vary from months to years. So the presentation can be very late as 20 years from the initial presentation. And you can get chronic proctitis, ulceration leading on to perianal edema, and there can be fissures radiating from the anal margin. So a perirectal examination and proctoscopy is a must, especially in the late stages and in the early stages, so that you don't miss any case of proctitis. So you do the perirectal examination, feel the rectal mucosa. It can appear edematous, or you can feel the ulcerations. In late stages, you can feel the rectal stricture. You can examine the finger for any blood-stained discharge and feel for the submucosal swellings, which are due to the lymph node enlargement in the perirectal areas. And the fibrosis can lead on to rectal strictures, which is often felt with the rectal examination. And also the fistulas, if present, also can be detected by doing a rectal examination. And the various strictures that manifest can be either annular, tubular, diaphragmatic, circular, or conical, and most commonly being the annular strictures. There is nothing but digital-ano-rectal examination, which will help you to find the nodulation and ulceration distal to the stricture. And the lymph nodes, the perirectal lymph nodes can separate, and they can cause perirectal, perianal abscess, ischiorectal abscess, which are all the complications seen in the tertiary stage, and rectovaginal and urethrovaginal fistulas. And a very late complication of elephantiasis is of course a malignant degeneration, and you can also get a rectal malignancy as a late complication of rectal stricture, which can occur in about 2 to 5% of cases. So to summarize, you have the early manifestations in the form of genital ulcers and inguinal syndrome and ano-rectal syndrome, and the late complications like genital elephantiasis with superadded genital ulcers, rectal stricture, lymphoids, perirectal abscess, anal fistula, and in females you can get frozen pelvis and infertility. So these are all the different clinical manifestations you can get in LGV, depending on the stage in which you see the patient. So coming on to the differential diagnosis of LGV, if you are coming across a patient with proctitis, with rectal discharge, then in addition to LGV, you should also look for other STIs like syphilis, gonorrhea, non-LGV chlamydia, the same organisms, LGV D2K causing non-gonococcal urethritis can also cause proctitis. Herpes simplex virus also is a differential diagnosis. And rarely, if there is a coexistence of HIV, you should also suspect CMV, cytomegalovirus can cause perianal ulcers. So these all conditions come in the differential diagnosis. So unless you exclude one by one, you may go wrong. And the differential diagnosis of Bubo has already been dealt. The chancroid, the indolent Bubo of syphilis, the pseudo Bubo you get in donovenosis, and the non-STI causes like lymphomas and tuberculosis will come in the differential diagnosis of Bubo. If it is an ulcer genitalia, again, the other causes of herpes simplex, syphilis, chancroid, and donovenosis. And recently, we had an ulcer in the genitalia, an unusual cause of an STI, which has not been designated as an STI, but this was a case of multiple genital ulcers, which we saw recently, and the diagnosis was monkeypox, which will also come in the differential diagnosis. And he had contact with a female. It was a heterosexual contact who had lesions in the oral cavity and face, with typical lesions of monkeypox. So coming on to the differential diagnosis of genital elephantiasis, this is a case of donovenosis, which presented with unilateral lymphedema of the vulva. And there are also cases, we have come across cases presenting as chronic lymphedema with ulcers and discharge in cases of metastatic Crohn's, where if you take a biopsy, you get sarcoidal granulomas, and you need to do a colonoscopy to differentiate it, to make a definite diagnosis of Crohn's disease. The other differential diagnosis of genital elephantiasis include filariasis, malignancies, and donovenosis. So we need to add tuberculosis, of course. The other picture is that of tuberculosis, which was treated with anti-tuberculous drugs, but then they could not prevent the late manifestation. And then finally, surgical intervention has to be done for the to improve the quality of life of the patient. Now, genital elephantiasis in males can, again, the differential diagnosis include donovenosis, which can have elephantiasis as a late manifestation, Crohn's disease, tuberculosis, malignancy, and filariasis. So LGV is mainly a diagnosis of exclusion. So you need to exclude these conditions before we make a diagnosis of LGV, as many of the tests which are available are not going to we are not having the sophisticated tests like nucleic acid amplification test to make a definite diagnosis of LGV. So we need to differentiate it from these conditions before we call it as LGV. Now, so in coming to the diagnosis of LGV, as I mentioned earlier, some of the cases may present with proctitis. So you need to do that is Digital-ano-rectal examination and a proctoscopy. And in females, you need to do a bimanual per vaginal examination to look for any pelvic mass and a speculum examination. And it's advisable to do a swabbing for the exudate, either the anal or vaginal or cervical exudate, before you perform this digital examination, as the lubricant that you use may interfere with the testing technologies. Now, briefly into the etiopathogenesis, that is this chlamydia trachomatis. As you all know, the ABC will cause trachoma, and D2K are the serovas which cause non-gonococcal urethritis, and the serovas L1, L2A, L2B, and L3 are the ones which cause LGV. And they have two forms. The infectious form is called the elementary body, which will enter into the columnar epithelial cells, and then it transforms into the reticulate body. And then the reticulate body by binary fission will form again, convert into the multiple, it will divide, and then it will come out as again elementary bodies, which are the infectious forms of the organs. And the ligands, the major outer membrane protein, which is rich in cysteine, which will attach to the columnar cells with the help of heparan sulfate. Now, it is very difficult to isolate this chlamydia. So if you get the discharge from Bubo or from the rectal exudate, culture is done in cell lines, HeLa cell lines, or in the yolk sac of chick embryo or McCoy cell lines. And the recovery rate is very low, that is around 50%. And because of the difficulty in doing the test, it is not routinely done. An electron microscope examination is needed to demonstrate the hexagonal appearance of the organism, which is also not available, which I could see when I went to China, in one of the institutes in China. Now, if there is a Bubo, you can go for a histopathology if there is a definite diagnosis cannot be made. And from the lymph nodes, you can make out a stellate microabscess, which is very characteristic of LGV, with poorly formed palisade of epithelioid cells, giant cells, and histiocytes. Sinus formation also may be seen, and fibrosis in the late stage. And you can demonstrate the organism as the ones which will be stained black with Wharton's starry stain. Other stains like Machiavello and Giemsa has also been shown to demonstrate the organisms, but it is difficult to see the organisms under the light microscopy. Direct immunofluorescence and immunofluorescence antibody staining techniques can also be used in chlamydia, where you can get an apple green fluorescence for the organisms. The organisms will be clustered within vacuoles. Both the reticulate and elementary bodies are better seen under the electron microscope. Now, there is also an intradermal test, just like you have the ITER test in Chancroid, you have the Freis test, described by Freis, and it is mainly of theoretical interest. The antigen was obtained from the Bubo initially, and later a ligranum antigen has been obtained from the culture in chick embryo. And you inject 0.1 ml into the forearm, and a control also is injected from the uninfected yolk sac into the other forearm. And if you see a papule about 6 mm in size after 48 to 72 hours, it is considered as a positive test, but it can remain positive for years together, and it cannot differentiate it from other types of chlamydia, and so it is no longer used nowadays. So coming to the diagnosis, like if you come across an ulcer, you do smears for herpes simplex virus if there is a PCR available. Multiplex PCR will help you to differentiate it from other STIs. Nucleic acid amplification test is the gold standard for diagnosing chlamydia, and you need to differentiate it by multiplex PCR from other strains of chlamydia. And in case of Bubo, you can take the aspirate from Bubo and do nucleic acid and culture for both Haemophilus ducreyi and LGV. If it is proctitis, you can take the anal exudate for gram stain, sang smear for HSV. And if you see more than 10 WBCs, then it is very suggestive of proctitis. So to confirm proctitis, a simple sang smear and gram stain can be done. And if there are more than 10 WBCs per high power field, you can take it as proctitis. And for confirmation, you need PCR. You can also do a dark field examination and serology to exclude syphilis. Now, routine blood test will show leukocytosis and polymorpholeukocytosis. The liver function, renal function, and has to be done, as sometimes systemic spread can occur. So you need to assess whether there is any systemic spread, and at the same time do other investigations to rule out other STIs like hepatitis B and C can coexist as with HIV. It can also have many of the cases of LGV proctitis have coexistent HIV infection. And you also get a hypergamma globulinemia in LGV, where you get increased IgG, IgA, and IgM immunoglobulins. So the gold standard is nucleic acid amplification test. The first step is the PCR, and second step to detect the different LGV biovars, you do a real-time PCR-based assay or a quadruplex PCR-based assay is done to differentiate between the various biovars. The serovars are differentiated when you do serological tests, whereas you call biovars when you do nucleic acid amplification tests. The various serological tests which can be done as mentioned for epidemiological purpose, you need to have a 4-fold increase in these serological tests to definitely say that it is LGV. So these tests like complement fixation test, microimmunofluorescence test, single type L-type immunofluorescence, immunoperoxidase, and radioisotope precipitation tests are all mentioned, but it is difficult to differentiate it from other serovars. Now, in late stages, you may have to go for radiological evaluation to know for the involvement of the rectum. You can do a barium enema and a CT or MRI for the involvement of pelvic lymph nodes. And other investigations, depending on the differential diagnosis, to differentiate it from other causes like filariasis, you go for a night smear. You can do chest X-ray to differentiate it from tuberculosis, and Crohn's disease, you do scopy and biopsy. In malignancy also, you need to do a biopsy. Now, coming to the treatment of LGV, the CDC guideline, doxycycline is the treatment of choice, 100 milligram BD for 21 days. And in the syndromic management of LGV, the Bubo kit is the black kit, where we give doxycycline, again 100 milligram BD for 3 weeks, and azithromycin 1 gram, which will cover both Chancroid and LGV. Now, preventive treatment can be given for LGV if nucleic acid amplification test is not available and if the clinical features are fitting in with that of LGV. And sometimes if the lesion still persists, you can also empirically give treatment for herpes simplex virus. Now, the antibiotic course may have to be prolonged in cases of if there is a coexistent HIV and if the Bubos are persisting, or if they have severe features like systemic disease. So the goal is to prevent the ongoing tissue damage. So you can increase the number of days of doxycycline, or you can go for alternative drugs like erythromycin or chloramphenicol. Sulfonamides have all been mentioned in the therapeutic armamentarium of LGV. Now, in special situations like pregnancy, lactation, and children below 8 years, erythromycin is the drug of choice. The base erythromycin is given during pregnancy for 4 times for 3 weeks, or you can give azithromycin 1 gram weekly for 3 weeks with a cure rate of around 97%. As erythromycin can cause severe gastrointestinal side effects, we may even go for azithromycin 1 gram weekly for 3 weeks. And ideally, CDC recommends a repeat testing for test of cure is done at 4 weeks. Now, as already mentioned, if the Bubo is about to rupture, there is IND is contraindicated. You aspirate. Multiple aspirations can be done with a wide bore needle from the non-dependent portion. And follow-up, as in all STIs, is a must. A detailed clinical examination and retesting for chlamydia. If positive in the initial test, then you can do a retesting after 3 months. If not possible at 3 months, they advise at least within 1 year. And also repeat clinical examination and testing for other STIs, as long incubation period of syphilis and the window period of HIV can be missed in the initial examination. As I mentioned earlier, DARE and proctoscopy, that is digital rectal examination and proctoscopy, can be done at later visits to look for any late complications like rectal stricture, as we see this more in the MSM population and with coexistent HIV. So coming to the late complications, a prolonged course of antibiotics may be needed. In rectal strictures, you can dilate it by using manually with a finger, or you can use rectal bogies. Surgical repair may be needed for ano-rectal and rectovaginal fistulas with the help of a surgeon. And also in case of elephantiasis, you may have to excise and flap surgery is needed for improving the quality of life of the patient. Now, as in all STIs, partner treatment, all sexual contacts within the last 60 days have to be tested for chlamydia infection and promptly treated. And they should be counseled and educated for the proper use of condoms. All asymptomatic partners are presumptively treated with doxycycline 100 mg twice daily for 7 days. So to summarize, LGV is caused by Chlamydia trachomatis L1, L2, L2A and L2B, being the strain. L2B was the strain which was responsible for the recent epidemic. And there are 3 stages: the primary, secondary, and the tertiary stage. So early diagnosis and prompt treatment is very important to prevent the late complications. And empirical treatment can be considered in resource poor settings, and you have to exclude other coexistence of other STIs, which are very common with LG.
Very nice presentation, and we all enjoyed the presentation. So I think postgraduate students are benefited out of these 2 presentations. Even though they are not coming across cases so frequently, it is always a help in their future practice as well. Definitely, in the examination, there may be a few questions among these STIs. So hope they will be benefited. Thank you, Dr. Betsy, for your nice.
Thanks.